great. Thanks so much. We're just starting to get questions coming in, but I actually have a few for you while waiting for everybody to put theirs in. One of them was, if you talked about generics and biosimilars, and thanks for clarifying that, because that does come up a lot about what the difference between the two are. If I've heard of this before, if you don't want a generic, like if you want the actual product and don't want the generic, do you need to let your pharmacist know that, so that, because will they automatically just give you a generic?
So the general rule is that unless the doctor writes on the prescription, there's a box that they can check that says dispense as written. The rule is that a pharmacist will substitute with a generic if it is available. If you do not, as a patient, would want a generic medication and your doctor has not selected dispense as written, you can let the pharmacist know, but you would need to let the pharmacist know that you do not prefer the generic medication. So you would prefer the brand. One thing that I will note, oftentimes this will require an insurance authorization in order to get approval for the brand name product when there is a generic available. So there is an extra step that often will be required if this is the case, that the generic is not going to be used.
Okay, thanks. One from one of our watchers today, our viewers, is there a difference as far as the insurance company is concerned with a med that needs prior authorization versus one that is considered excluded?
So that's a very good question. So sometimes, and I use the word sometimes a lot in this process because every insurance plan is different, and oftentimes situations are different where a medication, an insurance company might approve a non-preferred or a plan exclusion because of the situation. So in general, a plan exclusion means that it's something that's not going to be covered by the plan. That language, plan exclusion, versus insurance saying that it's not preferred. If it says plan exclusion, oftentimes they will not cover it. However, there are some scenarios where if you can show that every other option has been either exhausted or is not available as an option, occasionally you will be able to get coverage in that case. Often what we do with plan exclusions, if it's the right medication, if this is something that somebody absolutely needs, we can pursue patient assistance even if the medication is not covered by insurance.
Okay, great. Thanks. Somebody just asked a question about the copay card that I thought, well, that's a good question. I'm confused about how the copay card works. Do they cover the cost of the medication except for the copay?
So what happens with a copay card, so say you have a medication that's approved by insurance and you call the pharmacy and it's $100. What happens when you provide the copay card to the pharmacy, they basically run it like a second insurance plan. And what happens is it'll knock your contribution down to, usually it's like $5, sometimes it's $0. So what it basically does is it knocks the cost down to something much more reasonable that is affordable for you.
Okay, that explains it. I did have a question. If you do the appeal for a denied medication, you go through the appeal process. How long does that usually take? I was in a situation one time with my Rituxan that they had to do that. And I was just wondering, how long does it usually take?
It all depends on the insurance company, and it depends on what they consider as an urgent appeal. So some insurance companies, we have a pretty fast turnaround, usually 72 hours with those insurance companies. Sometimes if they've deemed it not urgent, they will take up to 30 days to do a determination on the appeal. A lot of times with medications like Rituxan, they hopefully, knock on wood, would consider it an urgent appeal because oftentimes there are parts of your body that could be at risk for developing severe complications if you don't get the medication in a timely fashion. So they may determine that that's urgent. But, we've had appeals that go up to 30 days for some insurance plans.
And have you heard about the Medicare situation that you brought up, that Medicare doesn't get copay cards, but that sometimes there are programs, but there's a lot of people that say middle America earns enough money not to get any assistance. And it sure seems unfair when just about anybody can get a copay card. Is there any room for change on that, or?
In terms of the Medicare rules, I don't believe there's going to be much change. However, in the coming years, fortunately, with the Inflation Reduction Act, if it keeps going in that way, in the way that we want it, the patient's responsibility should hopefully be decreasing significantly for a lot of medications. So fingers crossed that these things keep happening to reduce the burden of medication costs for people, because it can be a lot of money out of pocket for these medications. And I'm always pushing our partners in industry to try and increase the income threshold so that we can get access to medication for more people, because it's a game changer for everybody.
Yeah, I heard that recently with a friend, a big change for her. Anyway, next question is, if you have any issue with a generic and the allowed fillers seem to be a problem with one generic versus another, how can you go back to a specific manufacturer?
So that's something, if it's a specific generic manufacturer, that's something that you can request at the pharmacy level. So you can say, like, hey, can you please put on this prescription that I prefer this brand? And they should be able to put that in your profile. And hopefully, as long as that medication is available, you should hopefully be able to stick with that brand. Most pharmacies will order a specific brand for you. Every once in a rare while, there will be an insurance plan that that kind of excludes certain generic medications. But oftentimes, if we're able to prove through an authorization that you've had issues with this specific brand that the insurance prefers, oftentimes we can get it covered for you, so that you can continue on the medication that doesn't cause you issues.
That's a great pointer for us. There's a question about how to find out before selecting Medicare pharma plan, which plan covers monoclonal AB, such as Actemra for GCS.
So I would highly recommend anybody with Medicare work with a Medicare broker. They are very, very helpful in terms of helping you through the process of understanding, what is covered on certain plans. A Medicare broker does not cost anything to you as the patient. They get all of their fees from the Medicare Part D plans. So highly recommend Medicare brokers. You can always search a Medicare broker in your area, and they're super helpful with being able to direct you to a plan that might be best for you.
Okay, great. Thanks. One patient asked if Rituxan is an infusion center only, or can it be home infusion?
There are some places that do home infusion Rituxan. Usually they will require you to get your first dose in an infusion center, a medical center like setting. But there are some home infusion centers that will do, or home infusion companies that will do Rituxan as home infusion. It also all depends on your insurance. Sometimes they don't allow for home infusion.
Okay, thanks. I never knew that. And how hard is it to stay with the original biologic if a biosimilar is available? Having taken the original successfully with no side effects, I don't really want to take the risk of a biosimilar.
So, it all depends on the insurance plan. Some of them are a bit more flexible. Usually what happens with, and we're kind of seeing this now with all of the Humira biosimilars, although it may change in January. Usually what happens is, for at least some period of time, they will keep the originator biologic medication on their formulary at what they call at par, or at similar coverage with the biosimilars that they prefer. If the medication is not interchangeable, you may be able to make the case that you've been on this medication for this amount of time, but it might be a hard case to make. This is something that is it's a bit newer to our space, so we're kind of getting acquainted with what the insurance companies really want. So it's a hard one, definitely. But oftentimes insurance companies, for at least a while, will keep the originator on their formulary.
Okay, and this one is about weight loss medications. It says, my doctor's looking at a weight loss med because I'm so stuck with the prednisone impact. With high blood pressure and other issues, I really need to lose weight. My insurance is not covering basically any of them since I don't have diabetes. So I asked so much of my doctor. I hate to ask them to go through the appeal, but the weight is impacting my health.
So that's a very, very interesting topic. So there are some insurance plans that just at this point, they're not covering the weight loss medications, which is unfortunate because they're very, very helpful for people with rheumatologic disease for multiple different reasons. For people who are having significant weight gain while on prednisone, and then for our psoriatic arthritis patients, we know that if they lose a bit of weight, sometimes their disease gets a little bit better. So it's a hard topic. Sometimes it's just a plan exclusion that they won't cover, which is unfortunate because these medications are very helpful for a lot of people.
So in that case, do you need to go to your doctor and say, is this a plan exclusion or is this something that's just been denied?
So that's definitely a conversation with the doctor's office that I would have. Oftentimes it will say in the language of the denial what the deal is. Sometimes if you can make the case for use, they may approve it, but sometimes it's just a plan exclusion and they will not allow it.
Okay, and everything's worth, the information is great because everything's worth trying. Another one that we got is if you can you call a drug manufacturer about a special discount program where the patients get discount, like one-time discount on meds that's not the same thing as a copay? Is there something like
that? So not that I'm aware of. I'm not sure what that writer might be referencing.
Okay.
There are not one-time discounts that are provided. So either it's through insurance and copay card, through Medicare insurance and patient assistance. And then occasionally for medications that are not covered by insurance, there are certain situations that you can get patient assistance without using insurance. But that's definitely something for a doctor's office to look into. If a medication, say, is a plan exclusion, or sometimes we do this for rare disease that the insurance isn't covering, we will try to get patient assistance if the person doesn't have the medication covered.
Okay, and I did have one more for you. You said things that you can ask your pharmacist. I was just thinking about like people, sometimes the medication that we're asked to do, for instance, many of us with vasculitis have blood clots, and then we're all of a sudden put on blood thinners, and then we have to give ourselves shots, and then the medication is dispensed to us after hours that our doctor's office is closed, and we've never given ourselves a shot before. So what do we do?
So I would hope that the pharmacy dispensing it would walk you through, or before you get the medicine, somebody might be able to walk you through doing the injection. So like when the doctor's office is prescribing it, or if say you're in the hospital and they're prescribing it for you, hopefully somebody would be able to walk you through that process. If anybody's telling you that you're giving yourself an injection for the first time, definitely raise your hand and say, I need help. There are some resources online that actually will provide good education. So I know that that Johns Hopkins actually has a fair amount of injection videos online that you can watch that will provide additional information, even if it's not a medication that's like a branded medication. The branded medications, oftentimes they have a very nice website with very nicely done videos on how to inject yourself. But if it's an older medication, say a blood thinner, there are oftentimes videos that are provided by Johns Hopkins. They're on YouTube. You would just have to search like a Johns Hopkins injection video, and they're really good at walking through. But definitely always advocate and say, I've never done this for myself before. Can I please have some help? And hopefully somebody should be able to walk you through it. But definitely, like if you have a medication coming from the pharmacy, hopefully the pharmacist can spend a couple of minutes with you just to walk you through so you can feel a bit more comfortable with the medication.
I mean, that's great advice. It did happen to me. I had no idea what to do. It since happened to somebody else I knew, and I told them what I did. I called a friend who was a nurse, and she was sweet and came over and helped me. But I'd heard that a pharmacist can help you if it's after hours, if you ask for the help. It's just that so many of the pharmacists are like short staffed now. Everybody worries about asking for those things, but that's great advice. Thank you. I had one more. If a patient gets covered for Rituxan and the med did not really help or seem as effective as they would have liked, is it harder to get covered for it a second time? If I guess that means if they didn't, if they reported that they didn't get the results, is it hard to get covered again?
Well, so situations change and medication approvals change. So, it could be sometimes if, say, Rituxan didn't work the first time, say you took it maybe 5 years ago, didn't do a great job for you. There are new medication approvals all the time. So medications that can be taken with Rituxan. So for certain types of vasculitis, there's a new drug called avacopan that might be helpful. So situations change, and if the insurance might require an appeal. In that case, if in the past you haven't done so well on it, but the insurance might not require an appeal. My answer to that is situations change, science changes, information changes. So if that's the route that your doctor finds most appropriate for you, definitely pursue it 100%.
Okay. And speaking of avacopan, also known as Tavneos, this question is about that. It says, I was prior authorized for Tavneos by my pharmacy, but the copay is still expensive. The specialty pharmacy tried getting patients assistance. I was denied assistance as they said my diagnosis, EGPA, was not approved by the FDA. I was surprised that my pharmacy approved it, but the company refused it.
So I think it's worth having the doctor's office reach out to them. It's EGPA is a type of ANCA-associated vasculitis. So I'm not sure what if it's being used with rituximab or cyclophosphamide. I'm not sure what the situation is, but I would say have the doctor's office definitely reach out to the Tavneos Connect program and have them take a look at that, because maybe the form just needs to be tweaked slightly to indicate just ANCA-associated vasculitis and not EGPA.
So have the doctor's office ask Amgen for their help.
Correct. Well, not just Amgen. Like I would, so if they have a field access specialist that they work with, so the field access specialist is somebody who they're HIPAA cleared, so they can speak about patient information. Field access specialists usually are very, very helpful with this kind of stuff. So the doctor's office, definitely I would have them reach out to their field access specialist and see if there's something that they can do, because I'm not sure why they would be denying that for EGPA, because it's a type of it's ANCA-associated vasculitis.
Can you talk about how the pharmacy benefit managers impact the system? The cost seems to change all the time.
Cost to patients, or
It just says talk about how the pharmacy benefit managers impact the system.
I'm not entirely sure the intent of the question. So I can say that pharmacy benefit managers sometimes are a bit difficult and a bit particular. And I could I could spend an hour talking about how pharmacy benefit managers are not necessarily always our favorite in terms of cost and access. But in terms of cost to the patient, usually what happens for commercial plans is for that year, your copays are your copays. Your deductibles, meaning the amount that you might have to pay up front before you start doing your copays or coinsurances, that should be the same in any given year. For Medicare patients, the Medicare pricing structure is the Medicare pricing structure for your specific plan. There's a maximum that they're allowed to charge for a Medicare Part D program. And depending on which plan you get, the pricing structure might be a little bit different, but your copays will probably go up and then down and then up and then down based on where you are in the Medicare pricing structure. It's very confusing, but it's...
I was just going to say that same person said, sorry, do they set the prices that we pay? I get confused at who sets it, if that makes sense.
Yeah, so it is the price that you pay if you're going through your insurance is based on the pharmacy benefit manager. Yes, they're the one that dictates that price.
Okay, thank you. The next person said, can an insurance company stop covering a drug like Actemra even if they had a 1-year authorization approved?
So with the 1-year authorization, it is just that. So you still every year will need to go through the prior authorization process. Now, especially this time of year, a lot of people are getting letters from their insurance company saying that they're changing their formulary. So you might get a letter that says, we're no longer covering Actemra. But in reality, that's not necessarily true. For most plans. So what happens is they say, basically what they're telling you is this medication is moving off of our preferred drug list. We're requiring a new prior authorization. But if in most cases, I hate having to say that, in most cases, if we do a prior authorization for the medication that shows that you, number one, have a diagnosis where you absolutely need this medication, or number two, you're doing really well on this medication and it would be inappropriate to stop, oftentimes the authorization is renewed for another year. So those authorization timelines, the authorization is approved for that timeline, and it doesn't mean that the approval is going to end there. It just means that a new authorization is required at the end of that time period, if that makes sense.
That's crazy.
It is.
I just saw one question come in. Even after the appeal, Avacopan cost me close to $13,000 per year. It's a very high cost for someone who's 75 years old living on Medicare. Any thoughts? It's just
if you're not eligible on Medicare for patient assistance, then unfortunately, I hate to say it, that's what it costs. It's very unfortunate, and the discussions with the manufacturers about increasing the income thresholds are
right.
ongoing.
Well, we appreciate everybody who's working behind the scenes on that. And I think our final question for today is, I've been denied coverage for mycophenolate sodium for treatment for my MPA. I've gone through 3 appeals, physician letters provided, and Medicare Blue Cross Blue Shield supplemental insurance denies coverage. as the drug is not FDA approved for my condition. Do you have any suggestions?
So this is something that we run into with some Medicare plans where they will only cover medications that are either FDA approved or listed as diagnoses in what they consider approved compendia, so certain medication resources. And it's unfortunate because, it kind of leaves those who have a bit more of a rare disease in a lurch. I can tell you specifically with mycophenolate, Genentech does offer a patient assistance program for those people who might have been denied coverage. So I would recommend that this person, if they have not pursued it, to pursue Genentech patient assistance for, it's the brand Cellcept. But they may be eligible based on income for that patient assistance program for the denied medication.
It's so interesting from one Medicare plan to the next that happens, because I was on Cellcept last year on Medicare with no problem. So
it's not every plan, but there are plans, unfortunately, that do, and they're allowed to do that within Medicare law for certain diagnoses and medications. But it's very unfortunate that is the case, because usually we should be able to make the case that why this is a medication that is medically necessary. But sometimes I think a takeaway from this is sometimes there is assistance available through the manufacturer when we don't have access through insurance. Not always, but sometimes there's assistance through the manufacturer.
Well, we know what to do now, because you just told us all the extra things that we can do to help fight for ourselves. So, Dr. Parrott, thank you so much for all of your time today. We got so many thank yous in the chat. I can't even tell you how many they were. They loved this. It's an indicator that we will do another one early in the new year, probably, because it's something that we it comes up over and over and over, and it comes up at different times in people's lives. So we appreciate your time so much. And as always, we will finish this up and put this recording on the Vasculitis Foundation website for other people to be able to view that weren't able to be here. So thank you so much for your time today. We appreciate it.
Thanks so much for having me.